Active management of normal labor aims to achieve delivery of a normal healthy child with minimal physical and psychological maternal effects. Early anticipation, recognition, and management of any abnormalities during labor course. Antenatal preparation, maternal education about the physiology of labor and symptoms of impending labor. Breathing exercise, adapt the mother to breathing during labor to guard against respiratory alkalosis caused by hyperventilation. First stage of labor, history, or complete obstetric history, or history of present pregnancy, duration of pregnancy, medical disorders during this pregnancy, complications during this pregnancy as antepartum hemorrhage, or history of present labor, labor pains, onset, frequency and duration, passage of show, fluid or blood per vaginum, sensation of fetal movement, examination, or general examination, height and built, maternal vital signs, pulse, temperature and blood pressure, chest and heart examination, lower limbs for edema, abdominal examination, fundal level, fundal grip, umbilical grip, pelvic grips, FHS, scar of previous operations ECS, myomectomy or hysterotomy, pelvic examination, cervix, dilatation. The diameter of the external os is measured by the finger S during PV examination and expressed in centimeters. 1 finger equals 2 centimeters, 2 fingers equals 4 centimeters, and the distance resulted from their separation is added to the 4 centimeters in more dilatation. Effacement. Position, posterior midway, central. Membranes, ruptured or intact. If ruptured, exclude cord prolapse and meconium-stained liquor. Presenting part and its position. Station of the presenting part. Pelvic capacity. Investigations, if not done before, or if indicated, blood group Rh typing, urine for albumin and sugar, Hb%. Ultrasonography, active procedures, evacuation of the rectum by enema to avoid uterine inertia, help the descent of the presenting part, avoid contamination by feces during delivery. Evacuation of the bladder, ask the patient to micturate every 2 to 3 hours if she cannot use a catheter. It prevents uterine inertia and helps descent of the presenting part. Preparation of the vulva. Shave the vulva, clean it with soap and warm water from above downwards, swab it with antiseptic lotion and apply a sterile pad. Nutrition. When labor is established, no oral feeding is allowed, but sips of water. 15 milliliters magnesium trisilicate is given every 2 hours as an oral antacid to guard against bronchospasm. Occurs if the acid vomitus is inhaled during general anesthesia, Mendelssohn's syndrome. Antacid injections may be used instead. If labor is delayed more than 8 hours, IV drip of glucose 5% or saline glucose solution is given. Posture. Patient is allowed to walk during the early first stage, particularly with intact membranes. If rest is needed, the patient lies on her left lateral position to prevent inferior vena cava compression and hence placental insufficiency and fetal distress. Analgesia. Pethidine 100 mg IM, trilene inhalation, or epidural anesthesia are the most common use. NB. Patient should not bear down during the first stage as this is useless, exhausts the patient and predisposes to genital prolapse. The partogram. It is the graphic recording of the course of labor, including the following observations. The mother. Pulse every 30 minutes. Blood pressure every 2 hours. Temperature every 4 hours. Uterine contractions, frequency, strength and duration every 30 minutes by manual palpation, or better by tachography if available. Cervical dilatation, fluid input and output. Drugs including oxytocins. The fetus. FHR every 15 minutes by Pinard stethoscope or better by Doptone, descent of the presenting part. Degree of molding. Cardiotachography, if available, is more valuable for continuous monitoring of both uterine contractions and FHR, particularly in high-risk pregnancy. The advantages of the partogram allows right intervention in the proper time, e.g. oxytocin usage, instrumental delivery or CS. Allows different staff shifts to manage the case successively. A document for labor events. Second stage of labor. Its beginning is identified by the patient feels the desire to defecate. The contractions become more prolonged and painful. Reflex desire to bear down during the contractions. The expulsive effort is accompanied by sustained expiratory grunt. Rupture of membranes, although this is not specific as it may occur earlier even before start of labor. Pre-labor rupture of membranes, or later even to the degree that the fetus is delivered in an intact sac. Full dilatation of the cervix, 10 centimeters, in between uterine contractions, is the most sure sign. Delivery room. The patient is transferred on a wheel or trolley to the delivery room. Put her in the lithotomy position. The lower abdomen, upper parts of the thighs, vulva, and perineum are swabbed with antiseptic lotion. Sterile legs and towels are applied. Bearing down. Ask the patient to bear down during contractions and relax in between. Delivery of the head. The main aim during delivery of the head is to prevent perineal lacerations through the following instructions. I. Support of the perineum. O. When the labia start to separate by the head, a sterile pad is placed over the perineum and press on it with the right hand during uterine contractions. This is continued until crowning occurs to maintain flexion of the head. Crowning. O. Is the permanent distension of the vulval ring by the foetal head, like a crown on the head. The head does not recede back in between uterine contractions. This means that the biparietal diameter is just past the vulval ring, and the occipital prominence escapes under the symphysis pubis. After crowning, allow slow extension of the head, so the vulva is distended by the suboccipitofrontal diameter 10 centimeters. If the head is allowed to extend before crowning, the vulva will be distended by the occipitofrontal 11.5 centimeters, increasing the incidence of perineal lacerations. Ritgen maneuver. Upward pressure on the perineum by the right hand and downward pressure on the occiput by the left hand to control the extension of the head. Episiotomy. It is done at crowning when the perineum is stretched to the degree that it is about to tear. Swab and aspirate. The mouth and nose once the head is delivered before respiration is initiated and the liquor, meconium, or blood is inhaled. Coils of the umbilical cord. If present around the neck, are slipped over the head, but if tight or multiple, they are cut between two clamps. Delivery of the shoulders. Gentle downward traction is applied to the head till the anterior shoulder slips under the symphysis pubis. The head is lifted upwards to deliver the posterior shoulder first, then downwards to deliver the anterior shoulder. Delivery of the remainder of the body usually slips without difficulty, otherwise gentle traction is applied to complete delivery. Clamping the cord. The baby is held by its ankles, with the head downwards at a lower level than its mother for few seconds. This is contraindicated in preterm babies, erythroblastosis fetalis, suspicion of intracranial hemorrhage. This may be enhanced by milking the cord towards the baby to add about 100 milliliters of blood to its circulation. The cord is divided between two clamps to avoid bleeding from a possible second uniovular twin. Third stage of labor, delivery of the placenta. Conservative method. Put the ulnar border of the left hand just above the fundus at the level of the umbilicus to detect any bleeding inside the uterus, known by rising level of the atonic uterus. Wait for signs of placental separation and descent, but do not massage the uterus. As soon as they are detected, massage the uterus to induce its contraction. Ask the patient to bear down and push the uterus downwards to deliver the placenta. Hold the placenta between the two hands and roll it to make the membranes like a rope in order not to miss a part of it. Give ergometrine 0.5 mg or oxytocin 5 units IM after delivery of the placenta to help uterine contraction and minimize blood loss. These may be given before delivery of the placenta. Signs of placental separation and descent. The body of the uterus becomes smaller, harder, and globular. The fundal level rises as the upper segment overrides the lower uterine segment, which is now distended with the placenta. Suprapubic bulge due to presence of the placenta in the lower uterine segment. Elongation of the cord, particularly on pressing on the uterine fundus, and it does not recede back into the vagina on relieving the pressure. Gush of blood from the vagina. The active method, Brandt-Andrews method. With delivery of the anterior shoulder, 0.5 mg ergometrine or sintometrine, 0.5 mg ergometrine, plus 5 units oxytocin is given IM. When the uterus contracts, put the left hand suprapubic and push the uterus upwards while gentle downward and backward traction is applied on the cord by the right hand. When the placenta is delivered, it is rolled as in the conservative method. Advantage: reduction of the blood loss. Disadvantages: constriction ring may occur with retention of the placenta. Avulsion of the cord if undue pressure is applied. or inversion of the uterus if fundus is pressed while the uterus is lax. Routine examinations. Examination of the placenta and membranes, or by exploring it on a plane surface to be sure that it is complete. If there is missed part, exploration of the uterus is done under general anesthesia. Explore the genital tract, or for any lacerations that should be immediately repaired. Repair of episiotomy. Fourth stage of labor, observation for the patient, particularly atony of the uterus and vaginal bleeding.